Everyone, we have the privilege today of joining Dr. Melanie Harned to learn a little bit more about dialectical behavior therapy combined with prolonged exposure, also known as Dbt-Pe. Just to give you a little bit of background, dialectical behavior therapy was created in the late 80s by Dr. Marshall Linehan as a means of treating those who had borderline personality disorder or who are also at high risk for suicide or suicidal behaviors. So welcome, Dr. Harned.
Thank you for having me.
Yeah, importantly, Dr. Harned has worked extensively with Dr. Linehan in the creation of some of these, of DBT and in consultation. And so we really want to learn a lot more about how she came up with this protocol and where she's going forward with some of the research, the treatment. So if your patient is currently in DBT, at what point in therapy would it be appropriate for the patient to begin Dbt-Pe? Are there
Yeah.
any successes that the patient would have already accomplished to indicate that they're ready?
Yeah, that frankly was probably one of the most challenging things to figure out as we were sort of developing this approach, is like sort of like the $64 million question, like when is somebody actually ready? Like how do you know that? And so I can describe the criteria that we use while at the same time acknowledging that there's still a lot of subjectivity involved. It's a very much a clinical decision, and these are kind of principle driven guidelines for the most part of sort of how we think about this. And so the criteria kind of fall into the target hierarchy that we use in DBT. So DBT sort of prioritizes things with the number one priority in treatment always going to be life-threatening behaviors of any sort. And so similarly then, in thinking about when a person is ready to start Dbt-Pe, we need to not be worried about life-threatening behaviors anymore, or not incredibly worried about life-threatening behaviors anymore. So there's 6 criteria, and 3 of them kind of fall into that domain. So one of them is that the person is no longer considered to be at acute or imminent risk for suicide. And obviously, as we all know as clinicians, like that is a very much a subjective decision. There's no foolproof way to decide if somebody is or is not at acute risk. And so we're looking for the kinds of things we look for all the time in clinical practice, which is things like communicating suicidal intent, or having a plan, or actively acquiring means, things like that. And we do the treatment routinely all the time with people with high levels of suicidal ideation. That is not considered acute risk at all. It's got to be that paired with indicators that they're considering moving forward with their urges and thoughts soon. So acute risk has to no longer be a serious concern.
Understandable.
And then sort of second in that domain is that we do have a very clear rule that we follow in an outpatient setting. We require people to be free from any form of suicidal behavior or non-suicidal self-injury for at least 2 months before we would start the Dbt-Pe. And in more intensive treatment settings like IOPs and residential settings, we often shorten that to 1 month, just because there's a higher level of support available around them, and a shorter term treatment also usually. So, but there is this requirement that they be abstinent from those behaviors for a period of time and be able to demonstrate that they can use skills effectively, is this third criteria, that they're now effectively using skills to manage urges for self-harm and suicidal behavior when those urges arise. And we want to see clear evidence of that as well before we log in. So sort of that, or log in, start. So the first thing, basically, that whole set of criteria is about trying to make sure the person's likely to be able to do the treatment safely, without hopefully attempting suicide or self-harming. So that's the first 3. The second one sort of falls in our second domain of priority in DBT, which we call therapy interfering behavior, which is once we make sure that they are alive, we want to make sure that they are effectively engaging in the treatment before we're going to be able to get the treatment to work. And so from the perspective of Dbt-Pe, we also require that they are not engaging in any serious therapy interfering behaviors anymore before we start. And that's more about trying to make sure we actually think the treatment can be effective, and that we're going to be able to get a large enough dose of the treatment into them for it to work. So, the types of behaviors that might make us think that a person is not quite ready yet in this domain would be things like if they're very inconsistent in their attendance of therapy, for example, or they are never doing any amount of homework at all, or they're engaging in behaviors during sessions that make it so we can't actually do the treatment consistently. Things like, they dissociate for the entire session, or they're arriving at sessions consistently under the influence of drugs or alcohol, or spending session time yelling at us consistently, or whatever it might be that makes it very hard to actually deliver a treatment. So that's sort of another criteria, is we want some evidence that they are now able to effectively engage in treatment most of the time. We're not requiring any level of perfection, but it needs to be to a level where there's a good chance we think we can get the treatment into them. And then the last two criteria are more in our quality of life domain as we sort of prioritize things in DBT. So the one is that once we hit that domain, the clients actually, it's up to them what we are treating. And so they have to, one of the criteria is they have to actually want to treat their PTSD, and they have to want to do it now before we're going to launch in. Like, it really is up to them. And of course, we're weighing in and trying to help them make a decision to do the treatment if we think that's what's needed. But obviously, ultimately, it is up to them. So that's in there as well. And then the final one is often, frankly, the hardest one, and also the hardest one to make a decision about, which is the requirement that the client has now demonstrated both the willingness and the ability at some level to experience very intense emotions without doing something to escape from them. And so clients in DBT, I often view this as sort of the core skills deficit, is that they very often are unable to experience emotions when they start treatment for longer than a few seconds. Is pretty common, that they very quickly do something to get away from it, and that's what self-harm usually does, and suicidal behavior usually does. Drug use, the whole, 9 yards of the target behaviors we're addressing in DBT have that function most of the time. And so we also just need to see that now they've built up that skill, which in DBT is most often framed as mindfulness of current emotion, as sort of the skill that we have of just being able to experience an emotion and not do anything to try to change it, which is incredibly hard. But we want to see that skill is now something that people can do with at least for 20-ish, 30-ish minutes or so at a time, where we think we can get them through an exposure task without spending the whole time getting away from the emotion, so that it won't work. So
I'm curious, Dr. Harned, what adaptations did you make to prolonged exposure therapy as a part of developing the Dbt-Pe protocol?
Yeah, well, when we first started doing this, the for sort of beginning phase of my first grant, myself and my team, we went to Dr. Foa's clinic at the University of Pennsylvania, went to her training, and then she and her staff were very much involved in providing us with consultation and feedback in our sort of first round of clients that we were using the treatment with. So in all of that, we learned a lot from them, and we also were very clear that we were trying to stick as close as possible as we could to standard PE, given that it's an incredibly effective evidence-based treatment, and you didn't want to recreate the wheel when we didn't need to at all. So we were trying to stick as close as we could to it, and then sort of making changes only when we really thought it was needed. Either sort of two main reasons when we made changes. One was to make it more compatible with DBT. Like overall, I've made this into a word that doesn't exist, but we DBT'd PE. So we've sort of tried to turn it into something that fits very seamlessly into DBT and sort of uses similar, strategies and principles and things like that. So whenever there was a potential discrepancy, we sort of would shift things more in the direction of how DBT would approach it. And then the other sort of general thing was just we wanted to make sure it was fitting for our clients. So I can talk about a couple of examples of things we did end up making some changes to. So just as a high level point to make though, the whole time we're delivering Dbt-Pe, the expectation is that therapists are also adherent to DBT at the same time. So DBT is infused in the whole thing. We pull from all the strategies we have in DBT at all times as needed as we're delivering this additional protocol. So it's kind of a both and treatment. But some, sort of clear structural things that we changed about it. For people familiar with PE, in session 1, for example, you start with a trauma interview that's set up to pick one index trauma that you're going to focus on in treatment. One thing that was definitely clear in the population of clients we were working with is that it was going to be important to treat multiple traumas in the treatment. And most of them have had a lifetime of trauma starting from a very young age. And so we set up the treatment in session 1 with the plan to be treating an estimated number of 3 traumas is what we are set out to do as an initial treatment plan. The trauma interview is set up that way as well to sort of help clients narrow down their lifetime history to 3 of the most distressing events that we might target. And on average, we do end up targeting between 2 and 3 different traumas across the course of treatment. So that's sort of one thing that was about our client population, for example. And the other sort of thing about session 1, for example, is in standard PE, you have the option of teaching breathing retraining as a coping skill. In DBT, we have like a massive arsenal of coping skills that we teach our clients. And so instead of that, we put together generally we call it the post-exposure skills plan that can incorporate lots of different DBT skills, and we think that through in session 1 of which ones our clients can pull from as needed after doing exposure if they have very high urges for suicide or something like that is going on, or for whatever reason they would benefit from using some skills, and we bring in all the DBT skills to do that, for example. There's a sort of the next sort of structural thing that's maybe worth highlighting is in the second session, you focus on getting your in vivo hierarchy, exposure hierarchy set up. And one of the things we modified, which is again about our client population, was, shame is probably the most pervasive and painful and sort of disabling emotion that our clients experience. And so we wanted more ways to effectively target shame during the treatment. So we made a new category of potential situations to include for in vivo exposure, which are any kind of situation that elicits what we call unjustified shame in DBT, which is shame that does not fit the facts, meaning that if they were to share whatever it is they feel ashamed of, or make it public in some way, that they actually are very unlikely to get rejected. And so we build those kinds of tasks into our in vivo exposure as a sort of specific strategy for really going after shame as a particularly problematic emotion in our client population. I can say just overall, probably another notable difference is really the processing portion of the exposure sessions. After doing imaginal exposure, and you then process their experience of that and reactions to that, that processing part of the session is DBT through and through. And we approach that portion of the session really using an emotion regulation framework, which is consistent with DBT, where we get ratings beforehand of 6 or 7 different specific emotions right at the end of imaginal exposure. So we know what emotions are currently activated, more than just finding out their SUDS rating. So we find out if they have high shame or guilt or disgust or fear or sadness, like what's going on. And the sort of overall approach to the processing is to help them regulate the emotions that are really causing them problems still. And so very often we're targeting shame, we're targeting guilt, we're targeting disgust in that processing part of the session and trying to get those to be less intense, using lots of different DBT strategies to get there, which includes most of the time cognitive change strategies, trying to change some of the beliefs that are fueling those emotions. But we also have a wider sort of range of emotion regulation strategies we will employ that are not only sort of cognitively oriented. So So in a nutshell, there's lots more I could say, but it gives you some ideas of adaptations.
Can you speak a little bit about the past and the current research supporting the implementation of DBT-PE? How do these treatments combined compare to the use of either just DBT or PE as a standalone treatment for symptoms related to trauma?
Yeah, so so far there have been studies that have either been just open trials of the treatment by itself, as well as a randomized controlled trial and a non-randomized controlled trial that compared DBT alone to DBT with this extra DBT PE protocol. There hasn't been any research yet that's compared it to a standalone PTSD treatment like PE or CPT, so we don't have information on that, but we do have in comparison to standard DBT. So what we know from the research in general is that if you add in this extra protocol, first of all, that it's actually feasible to do that across the studies. Somewhere around half choose to initiate this extra protocol. And the reason that number is not higher, sort of the primary barrier that we run into in getting people to that second stage of treatment where we would add this protocol in, is that they drop out of treatment before then. So the biggest barrier is that they clients drop out of DBT before we can get them there, or the other barrier we've encountered more actually in my study in the public mental health settings was that the therapist dropped out of treatment. So
Oh.
the staff turnover is a significant problem in many community mental health settings, and that was our experience of doing this treatment there, is that the clients often stayed and it was the therapists who left. And so basically any major disruption in treatment during that first stage, of course, will make it impossible or unlikely to move on to the second stage. But most people do it, and of the people who actually complete the full year of DBT, almost all of them do it. So that's feasible to do, which is, one thing we had to find out, of course. And then the second thing that everyone was worried about, myself included, was, is this actually going to be safe to do? Can we get somebody through a trauma-focused treatment who 2 months ago was self-harming 4 times a week and tried to kill themselves, And so the answer to that has also been that we can. This has been safe to deliver. People are not showing increases in these behaviors compared to people who get DBT alone. And in fact, the opposite is true. So, in our randomized and non-randomized controlled trials, we've seen that people who do the extra DBT-PE protocol actually attempt suicide less often and self-harm less often during treatment compared to people who only get DBT. So it's possible it might even reduce risk to be able to offer this PTSD treatment. And then, of course, the end game is to actually treat their PTSD. And so the outcomes there also suggest that in comparison to DBT alone, if you add in this extra protocol, it doubles the rate of diagnostic remission from PTSD across samples. So definitely we got that big boost in effectiveness in PTSD by adding this in as well.
That's incredible. So one of the concerns tends to be increased self-harm or high levels of dissociation with exposure therapy. And I think you've addressed some of that, but specifically too, how do DBT-PE providers ensure appropriate levels of engagement in therapy? I know that when we're doing PE specifically, we talk a lot about under-engagement and over-engagement, and just really trying to find that sweet spot in order for therapy to be effective. So just
Yeah. Yeah, so that's another reason I love the fact that we've embedded this in DBT, because DBT, our sort of wheelhouse is teaching people how to regulate emotions. And so we can bring all of that into play during DBT-PE. So if we have a client who during exposure is reliably over engaging or consistently over engaging and dissociating, for example, which happens very frequently, and that's a very common problem in our client population, then we've got lots of DBT skills that we could have them use and coach them to use during exposure if needed, to sort of down regulate the intensity of their emotion in some way. So just to say clearly, our preferred method, our sort of ideal approach is that we're not having people actively using skills during exposure. And so it's only if we really run into problems, we'll add these in, ideally temporarily until they're struggling less with engagement problems. But so if they're overengaged, we would coach them very often to use our DBT crisis survival skills, for example. So we have a set of skills for, we call the TIP skills, which are about some sort of intense physical sensations and things that will reduce arousal quickly. So it's very common. We have people holding an ice pack, for example, during imaginal exposure who are struggling with dissociation. And we also, would coach in a variety of other potential crisis survival skills from DBT, like self-soothing or pace breathing or something like that, if needed, to downregulate. And then, while we do have a lot of overengagement, mostly in the form of dissociation, I think we have just as much, if maybe not even more, problems with underengagement. Our clients are also expert avoiders of emotion. And many of them really struggle to access emotions during exposure, sometimes intentionally. They're keeping them away, but very often they're not. Like they just are so numb that they can't get to the emotion. And so we also have skills from DBT that we'll bring to bear in that situation to upregulate emotions and try to get them more intense. In addition to some of the standard things we'd be doing in PE, like increasing the level of detail of the narrative and things like that, we'll also be coaching people in certain skills, like in DBT, our mindfulness skills, which is to pay very close attention and observing their own experiences and describing them out loud, sort of mindfulness of current emotion when it does start to show up, as well as a lot of acceptance skills, so radical acceptance in particular. Of needing to allow emotions. Willingness is a skill we teach, of being willing to do what's needed in a situation even when you don't want to, things like that, that will bring those skills in as well to try to get emotions more intense when we need them to be.
And thank you so much, Dr. Harned, for bringing that up. The fact that some of the clinicians that I'd spoken to about Dbt-Pe, I think that there was more expression about the concern about overengagement, but I think that you are correct that a lot of our clients do tend to underengage with their emotions. And so really kind of highlighting how we balance that out and how Dbt-Pe addresses that, I think will be extremely useful. So the PTSD research may tend to exclude those with borderline personality disorder or other strong comorbidities from participation in treatment studies for PTSD. Is there a particular reason this has been so in the past? And how do we kind of address this gap in the treatment and the research right now?
Yeah, so, just to say clearly, very few treatment studies for PTSD have actually used borderline personality disorder itself as an exclusion criteria. But the people who have it, particularly more severe levels of it, tend to be excluded on the basis of other problems they have. So because those studies do almost uniformly exclude people who have a recent suicide attempt or serious self-harming behavior, or who are believed to be at acute risk for suicide. Or who have any other problem that is a higher priority than PTSD. So very often they require PTSD to be the primary diagnosis. So for those reasons, people, often get excluded who have borderline personality disorder. But the reason for that, as best I understand it, having talked with lots of people and sort of, but is that these treatments, so like PE and CPT, are intended to be standalone treatments. They're intended to treat PTSD, and they're very good at that. But they're not intended to treat other things. And so they sort of assume that people begin treatment sort of wanting to and ready to immediately launch into a PTSD treatment. And so they use as exclusion criteria behaviors or problems that they think would potentially make a person not ready to immediately take that on. So that's why those criteria have generally been used in those studies, and those are the exact clients that we were trying to reach with this treatment, as the ones who would typically be considered inappropriate for those studies or treatments.
Dr. Harden, I'll slip this question in. For those who would be interested in becoming Dbt-Pe providers, where would you recommend they start with training themselves?
Yeah, they would need to start with getting trained in DBT. You can't do this treatment if you don't know DBT and if you're not already doing DBT. So this is intended to sort of add to your practice of DBT. So for a baseline, you've got to sort of get all the training that one needs in order to do DBT well. And then after that, so far, the sort of standard training option has been a 4-day intensive workshop that I do for people who are already trained in doing DBT, and with some availability for consultation, and we're working on trying to get that more available. So that's the sort of current standard training models available. Having moved more into sort of implementation research and just doing a lot of training, just to also say that like many DBT therapists are really interested in doing this, which is no small thing on that side either, to sort of being willing to take this on. DBT is hard enough, these clients can be hard enough to treat, but to add in sort of taking on the extra work and challenge and emotion and everything that brings up for therapists of doing a trauma-focused treatment, and people are very interested in it. And from a research perspective, that we have found that we are able to effectively train people. We've got a couple different studies looking at different modes of training, but generally that we can get people actually using the treatment and experiencing it to be effective for their patients. And we have some data that we can train people with no prior training in any PTSD treatment like this to start using it at a level of adherence that is comparable to our sort of research therapists in our early studies. So it's a treatment that we can actually train people to do and do it well, and that's very exciting.
And so, we know now that you're housed within the VA health system. So thank you so much for your service to our service, active duty service members, our veterans, and really their families. I know that, I work within a military treatment facility, and that it's just really exciting to be able to offer the very best to those who have served in uniform. And I'm also wondering, regarding the future of DBT-PE, for dream research or dream programming, if the sky were the limit, what's your vision for DBT-PE going forward from here?
Yeah. So I would love to do more research with veteran populations, and I hope to be able to do that at some point soon, but sort of doing a larger treatment trial inside the VA setting would be fantastic. I would love to do that. And I guess just broadly, sort of most interested in getting this treatment available to more people who need it, and sort of figuring out how to effectively disseminate and train people as we also continue to gather data about its effectiveness in a variety of different settings. And just sort of continuing to see whether its effects sort of remain robust as we sort of disseminate it out, which is ultimately the end goal, is to hopefully get it to the places where people most need it and where this treatment, DBT, is most often delivered, and hopefully have it still be as effective as we've found it to be in other places. So that's where I'm sort of headed, as more sort of implementation research on this and getting it out into the world. So
That sounds wonderful. I think that a lot more people could benefit from DBT-PE. So the more widely available that it's made, and the more trained clinicians that we have who are able to treat all the clients that might need it, sounds like it would definitely be a dream. So good luck to you, Dr. Harned. Thank you so much for your time today. Looking forward to hearing more about your research and just DBT-PE going forward. Thank you.
thank you so much for having me.
My name